بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا أكرم الأكرمين. Dear colleagues, now we are going to discuss an important issue, which is the imaging of the neck proper. And you know that the neck is generally divided from the imaging point of view into the suprahyoid neck, the structures above the level of the hyoid bone, and the infrahyoid neck. In the suprahyoid neck, we usually deal with the imaging of the floor of the mouth as well as the salivary glands. Then in the infrahyoid neck, we deal with the rest of the structures I will mention in the topic of infrahyoid neck. You remember that I have discussed already the imaging of the salivary glands, and now I will try to discuss the imaging of the mouth floor. This is the usual division of the neck into the suprahyoid component, which includes the tongue and the mouth floor, as well as the salivary glands. And the infrahyoid neck will include these topics: the cystic lesions of the neck, vascular lesions, laryngeal pathology, neck lymphadenopathy, imaging of the thyroid and the parathyroid glands. And you remember we have tackled this subject, which is imaging of the parapharyngeal spaces as a separate entity. You know, the parapharyngeal space has a component above the hyoid bone and another component below the hyoid bone. So I prefer to have this subject as a separate entity. In order to image this part, which is the suprahyoid neck or the mouth floor and the salivary glands, the patient lies in the supine position with a slightly hyperextended neck, and we have the scanogram in the lateral view. The slices usually cover the area from the hyoid bone up to slightly above the angle of the mandible, and the scan intervals are usually taken at 2 or 3 millimeter intervals. And we proceed, as I have mentioned, from the level of the hyoid bone to the hard palate, or from the hard palate to the hyoid bone, usually parallel to the lower edge of the mandible. Then we do not instruct the patient about respiration or swallowing, and we usually need to inject the patient with intravenous contrast media. Also in this area, the 2D reconstructed images are valuable in demonstrating the pathology, but the 3D images are usually of little significance here. Also, we can use the facility of virtual endoscopy by multi-detector CT. We display the images by the soft tissue window, and sometimes we use the bone window whenever you suspect lesions in the hyoid bone, for example, or in the mandible or in the cervical spine. For MR examination of this area, we use the same protocol. We use the head and neck coil. We should have the sagittal and the axial images, and also T1 and T2 weighted images. We may include the fat suppressed images before and after intravenous contrast injection, and sometimes we may use the facility of MR angiography to show the flow within some of the lesions. And this is not a significantly valuable technique, as I will mention after that. Then you see these are MR axial T1 weighted images for the region of the tongue and the mouth floor, we may concentrate on certain anatomic details. And here you see this is the mandible, and this is of course the masseter muscle, and on the inner aspect of the mandible you know the pterygoid muscles. And this muscle is the posterior belly of digastric, and here you see the oral cavity and the prevertebral muscles, as well as the muscles of the back of the neck. Then this is a very important section in the region of the mouth floor, because it shows one of the important anatomic landmarks here, which is this muscle. And this muscle is known as the genioglossus muscle, or let us refer to it by the letters GG. Then genioglossus or GG is an almost paramidline structure, and there is another one on the opposite side. Both muscles are separated by a very important anatomic landmark, which is the midline fat or fatty septum, or the midline anatomic fat, which is important, as I have mentioned, and I will mention its importance immediately. Then looking at this axial image, we can see the muscle I have mentioned, which is the genioglossus muscle. It lies in the mouth floor. This is the genioglossus muscle. It is attached to the base of the tongue posteriorly, and anteriorly it is attached to the back of the mandible. The genioglossus muscle, or GG, is separated from the opposite GG by this very important midline fatty septum or fat plane. Then you see this is the submandibular salivary gland on both sides, and here is another muscle which is also important, and this is the mylohyoid, and you can refer it by the letters MH just to remember this muscle. This is the MH, or the mylohyoid muscle, and this is GG, or the genioglossus muscle. This is the submandibular salivary gland, and this is the oral cavity. This is the sternocleidomastoid muscle on both sides. This is the right one, and this is the left one. Of course, you see the carotid and the internal jugular vessels. Once more, this is GG, which is a very important anatomic landmark in the mouth floor. The genioglossus muscle separated from the opposite one by the midline fat septum, and lateral to it, and you can see the MH, or the mylohyoid muscle, and between these two muscles you can see the lingular vessels. The lingular artery runs in this particular space. Then this is the submandibular salivary gland, and this is the right one, submandibular salivary gland. The sternomastoid on the left side and the sternomastoid on the right side. Of course, you know that this is a lymph node which is pathologically enlarged, related to the left submandibular salivary gland. And here is the anatomy of the mouth floor. The GG, genioglossus muscle, on both sides. Then the MH, which is the mylohyoid muscle, and this is the oral cavity, where you can see the tip of the epiglottis. I hope you remember this. And this is the glossoepiglottic fold, which divides the pre-epiglottic space into the two valleculae, as I have mentioned before in the lecture of the larynx. And here, this is the sternomastoid and the carotid vessels, the submandibular salivary gland on both sides. Also, you can appreciate this by MRI T1 weighted image. This is GG, the genioglossus muscle, and this is the mylohyoid or MH muscle. Then you have two small muscles here between the GG and the MH muscle. These two muscles are the posterior one is the styloglossus muscle, which is the muscle between the tongue and the styloid process, and the anterior one is the hyoglossus muscle, which a muscle between the hyoid bone and the tongue. And you can remember that hyglossus is anterior to the styloglossus because the letter H lies in the letters before the letter S. Then you know this is the hyoglossus and this is the styloglossus muscle. Then you can see this is the mastoid process and this is the styloid process, and the muscle coming from the styloid process to the base of the tongue, and this is the styloglossus muscle, and then the muscle coming from the hyoid bone to the base of the tongue, and this is the hyoglossus muscle. In the sagittal MR images you are able to see the tongue proper, and you can also see GG, which is the genioglossus muscle. Then you will see this muscle which connects the mandible to the hyoid bone, and this is known as the genohyoid muscle, and I will show it to you immediately. Then here once more, this is the anatomy, and you see the GG, genioglossus muscle, the midline septum between the two muscles, and the submandibular salivary gland. Then you see the MH and the two muscles which represent the hyoglossus anteriorly and the styloglossus more posteriorly. This is the submandibular salivary, this is the stylomastoid muscle and the carotid artery as well as the internal jugular vein. Then lower down to GG, this is the site of the GG separated from the opposite one by the midline septum, and this is the hyoid bone. This is the body and this is the greater cornea, as you know. Then below the level of GG you will see the genohyoid muscle, which is connecting the back of the mandible to the anterior aspect of the hyoid bone, and this is the submandibular salivary gland, and the stylomastoid muscle. Then below the level of GG you will see the muscle which is known as which is known as the genohyoid muscle. This is the muscle, I mean the genohyoid muscle. This muscle will connect the hyoid bone to the back of the mandible. Then you also see at this level an important muscle which is slightly lateral to the genohyoid muscle, and this is the anterior belly of digastric. The anterior belly of digastric, these two bellies are separated by fat anteriorly, as you can see here. Then this is the submandibular salivary gland on both sides. This is the sternomastoid muscle, as I have mentioned before. In the sagittal image you can see the tongue proper, the GG or the genioglossus muscle, and below it you will see the genohyoid muscle. And here you can appreciate this in the coronal plane. This is the tongue, and this is the submandibular salivary gland on both sides. This is the ramus of the mandible, and you can see the lateral and medial pterygoid muscles attached to the lateral pterygoid plate. Outside the ramus of the mandible you can see the masseter muscle. Then a more anterior section will show GG or the genioglossus muscle, and underneath the genohyoid muscle, this one, the genohyoid muscle, and more lateral to it, and you can see the anterior belly of digastric muscle. Then this section passes here, and this one corresponds to the green line. Okay, now we have discussed the issue of the lesions which can affect this area, and we have mentioned from the lecture of the parapharyngeal spaces that most of the lesions arising in the pharynx as well as in the mouth floor and the tongue are usually carcinomas. The malignant lesions are usually carcinomas of most commonly the squamous cell type. And whenever you see a lesion in this area and you suspect that this lesion is malignant, then you have to evaluate the extensions of this lesion into these areas. Number one is to assess the pre-epiglottic fat, and this is the epiglottis, and here the pre-epiglottic fat. Then you should look for invasion of the mandible and the maxilla, and then you see this is the mandible, and here is the maxillary sinuses, and as well as the alveolar margin. Then you look for invasion of the prevertebral muscles as well as the skull base or the cervical spine. Then you look for the retromolar trigone. Now you see this is the molar teeth, and the retromolar trigone is located here in this area. I am pointing to it. Then the pterygomandibular raphe is the space between the pterygoid muscles and the ramus of the mandible. Here, this is the pterygomandibular raphe, if it is invaded by tumor or not. Then one of the important issues, especially in the tongue and mouth floor, is to look for the midline fat plane, if it is crossed by the lesion or not, because crossing of the fat plane by the malignant lesion meaning that surgery is almost cannot be performed. Then the oropharyngeal carcinoma is just a soft tissue mass infiltrating the adjacent fat planes, and you should remember the anatomy in order to be able to describe the lesion. Then here you see an enhancing mass in the left side of the mouth floor, and this mass is not clearly separable from the genoglossus muscle. It is also affecting the lateral wall of the pharynx and is inseparable from the anterior part of the sternomastoid muscle, and possibly it infiltrates the two muscles here, which are the hyoglossus and the styloglossus muscle. But this lesion did not cross the midline. It did not affect the midline fat plane. Then according to the size of the lesion, we have this very simple staging. The T1 tumor is the tumor less than 2 centimeter in size. From 2 centimeter to 4, this is T2, more than 4 centimeter, and this is T3, extension outside the oropharynx, and this is stage 4. Then looking at this example where you can see an enhancing mass in the right side of the mouth floor, and this mass is confined to the right side. It has not crossed the midline. One of the important issues is to look for lymphadenopathy. Then if you look carefully here, and you can see this is the sternomastoid muscle, and this is the lower part of the parotid gland, and here you can see these lymph nodes. This is one lymph node, and this is the second one. Then you got some lymphadenopathy, metastatic lymphadenopathy ipsilateral to the tumor. And this is also an example which shows a mass of relative well-defined borders. It has infiltrated the mouth floor. It involved the genoglossus muscle as well as the fat plane in between, and also crossed the midline to the opposite genoglossus. And then the midline crossing of the lesion to the opposite side usually indicates that this lesion is not surgically resectable. In another case of carcinoma of the base of the tongue infiltrating the tonsillar fossa. This is the oropharynx, you remember, and this is the tumor. There is a big mass showing contrast enhancement infiltrating the base of the tongue as well as the tonsillar fossa on the on the left side, and this mass is of course crossing the midline, considering this particular component. This is a lesion which is located in the right side of the tongue, both in the axial and the coronal planes. The midline fat is intact and the tumor did not cross the midline and thus can be removed by hemiglossectomy, as you can see. Then crossing the midline is usually a sign that the tumor is not surgically resectable. Another example, here you see an enhancing mass in the anterior part of the tongue on the left side, and this tumor did not cross the midline and it can be surgically removed. And also here you should search in every case for metastatic lymphadenopathy in the scanned area, and in this patient particularly you cannot see enlarged lymph nodes. The same with MRI, and you see a big mass infiltrating the tongue as well as the mouth floor. And in the sagittal image you can see that the base of the tongue is totally involved. The mass is bulging in the pre-epiglottic space, and it has infiltrated the genoglossus and possibly the the muscle which is connecting the mandible to the hyoid bone, or the okay, this muscle I will remember its name immediately now. This is the genoglossus and this is the genohyoid muscle. Then both muscles are infiltrated by the tumor. The tumor has crossed the midline to the opposite side. It has significantly encroaching on the oral cavity or the oropharyngeal cavity. Then since this lesion has crossed the midline, there is no surgical options. And you remember I have provided many examples of carcinoma of the tonsil, and this is one of the examples. You see a mass which is located exactly in the tonsillar fossa on the left side, showing intermediate signal in the T1 and high signal in the T2 with almost uniform post-contrast enhancement. You should look, I repeat, you should look for enlargement of the lymph nodes. There is no here in this example. And you should consider all masses arising medial to the parapharyngeal fat as carcinomas until proved otherwise. Another example of carcinoma of the tongue and mouth floor. There is a mass in the anterior part of the tongue, and this mass has crossed the midline to the opposite side. It has infiltrated both GG muscles, the genoglossus on the left as well as the genoglossus on the right side. Then sometimes these carcinomas may invade the adjacent mandible, either by erosion or by marrow invasion only. In cases of marrow invasion, MRI is superior to the CT, where in cases of bone erosion, they said that CT is much better. Then you see a tumor here in the mouth floor, anteriorly to the left, and is associated with destruction of the adjacent mandibular margin with possible tumor extension beyond the confinement of the mandible. Then here you remember the buccal space, which is the space outside the alveolar margin, where the duct of the parotid gland usually passes outside the masseter muscle, then in the buccal space to enter the oral cavity opposite the second upper molar tooth. Then in this buccal space, compared to the opposite side, there is a mass, and you see this mass is homogeneously enhanced, obliterating the fat which is normally seen on the left side, and this mass has infiltrated the retromoral trigone as well as the pterygomandibular raphe. Both spaces are infiltrated, and this is the medial border of the mass, which in this example did not involve the tongue, but it is located to the buccal space and extended to the retromoral trigone and the pterygomandibular raphe. And you can appreciate, I don't think this is true, if there is some erosion here, but this is some irregularity which is related to the mandible. Then look carefully, searching for lymph nodes, and this is the submandibular salivary gland, and there is a group of lymph nodes that is related to the submandibular salivary gland and on the same side of the tumor, and you can see this enlarged lymph node which is metastatic. Then sometimes you also remember that most of the lesions medial to the parapharyngeal fat are on the carcinoma side, but there is some other lesions like lymphoma, for example, which can be seen in the pediatric age group as well as in adults, and some of the tumors that can be seen in the pediatric age group like rhabdomyosarcoma, for example. And this is an example of a pathologically proved non-Hodgkin lymphoma infiltrating the base of the tongue and the soft palate as well as the tonsillar fossa on the right side. Then you should also look for the enlargement of the lymph nodes, and you look for invasion of the adjacent structures. And this is an example of oropharyngeal non-Hodgkin lymphoma in a 62 years old male presenting with swallowing and breathing problems. In here you can see by this barium swallow there is marked stretching of the barium column over a very big mass here, affecting the region of the base of the tongue and the oral cavity. And you can compare this appearance by the normal configuration. This is the vallecula and this is the piriform sinus, which is markedly involved by the tumor. Then this is also a case of tonsillar large cell lymphoma. Look at this mass centered at the fossa of the left tonsil, and on both sides you can see bulky, homogeneously enhanced lymph nodes. They are located deep to the sternomastoid muscle, and these are lymphomatous nodes, of course. Then in oropharyngeal non-Hodgkin lymphoma, there is a mass in the right side of the mouth floor, and this mass has also infiltrated the adjacent part of the upper neck, and is not clearly separable from the related muscles of the mouth floor, as you can see here. And if you look carefully, you can see a big lymph nodes related to the site of the lesion. And also here, this is the sternomastoid muscle, and this is a lymph node, and this is also a lymph node, and this is the third one. And here you can see the submandibular salivary gland. And the tongue, being rich in the blood supply, is prone to metastatic disease, and the metastasis has no specific imaging findings, but you can predict that these are metastases by knowing that the patient had a primary malignancy. And in this patient who has a renal cell carcinoma, developed a mass in the base of the tongue and the mouth floor, encroaching on the oral cavity, and this was proved to be a metastatic deposit. And also here is a patient with breast cancer presenting by this mass destroying the mandible with extension outside and inside the borders of the mandible, together with other metastatic disease in the spine, and these are metastatic diseases in the mouth floor. Then sometimes, and this is not common, and you see a mass like this, then you think you are dealing with a carcinoma of the tongue, as we have mentioned, or the tonsillar fossa, for example, or in the differential diagnosis, maybe the possibility of lymphoma and metastatic disease if the patient had a primary malignancy. But this lesion has been removed, and it has been proved histologically to be a just rhabdomyoma. Then we came to the cystic lesions that can be seen in the mouth floor. These are mainly three types: the ranula, the dermoid cyst, and the epidermoid cyst. The ranula is a commonly seen cyst in the mouth floor in the clinical practice, and this is just a mucus retention cyst of the sublingual salivary glands. And we have two main types, the simple and the plunging ranula, but many times you cannot differentiate between both, but sometimes you can differentiate. This is the classic appearance of a ranula, a cystic lesion which is filled with fluid. There is no internal septations, no mural nodules, and no calcium, and no contrast enhancement. And this cyst is classically off the midline. It should be located on one side of the mouth floor, either to the left or to the right, as you can see here. And this is also an example of a ranula in the mouth floor, and this ranula is big, and it is extending into the submandibular space, compressing the submandibular salivary gland. Then ranula is a cystic lesion. By MRI, it will appear of low signal in the T1 and the high signal in the T2 weighted image. This ranula is located between GG, or the genoglossus, and MH, or the mylohyoid muscle. Then the simple type is the most common, but the plunging type is that ranula which is branching or penetrating or extending into the submandibular salivary into the submandibular space. In here you see there is a lesion which is of low signal in the T1 and high signal in the T2. In the sagittal image you can see that the lesion is branching and extending into the submandibular space. This is the submandibular salivary gland, and this is the opposite one, and you can see the extension of the lesion. Then dermoid and the epidermoid cysts are classically located in the midline plane of the floor of the mouth, and these masses are of course in the floor of the mouth above the level of the hyoid bone. Then if you think about epidermoid and dermoid, you may say that it is an easy process or an easy task to separate between dermoid and the epidermoid based on the presence of fat in cases of dermoid and the absence of fat in cases of epidermoid cyst. But actually both lesions can contain fluid. I mean, epidermoid and dermoid cysts may appear like this: a simple midline cyst in the mouth floor containing fluid. But you may spot the diagnosis of dermoid cyst if you can see fat inside the lesion. But if you cannot see fat inside the lesion may represent an epidermoid or a dermoid cyst. This cyst may be small or big, like this one in the floor of the mouth. And sometimes the cyst is not exactly in the midline. It has a component in the midline, but is slightly to the slightly off the midline. Then this lesion contains fluid and there is no evidence of fat. Then you think of epidermoid and dermoid as possibilities, and sometimes if there is fat you may got some fluid levels, and also In a few cases you may have marginal enhancement of the lesion, but this classic appearance, which is known as the sack of marble sign, is pathognomonic for the diagnosis of dermoid cyst. And this is what we mean by the sack of marble sign. And here you can see too many fat globules entrapped or located within a big cyst containing fluid together with these fat globules. Then if you see the sack of marble sign, and this is classic for the diagnosis of dermoid cyst of the mouth floor, the presence of fat is helpful to suggest the possibility of dermoid. But if you cannot see fat, the possibility of dermoid is still there. Then here you see a lesion in the T1 weighted image, it contains a fluid. In the T2 weighted image, it also contains fluid. But this was proved to be a dermoid cyst in the mouth floor. And this is a classic appearance of dermoid cyst, showing the classic sign, which is the sack of marble sign. And here by ultrasound you know that fat will show very bright echoes or being echogenic, while in the CT scan the fat will appear of dark density, and MRI T1 weighted image the fat will show bright signal. But this is not a lesion which is exactly in the midline, but the presence of this sack of marble sign or appearance is diagnostic for dermoid cyst. Then if you see a lesion like this, and this lesion did not show the sack of marble sign, it contains simple fluid, then the diagnosis will be a ranula, which is the cyst that occurs lateral to the midline plane. Also, sometimes you are confronted by this lesion, which is classic in appearance by CT and by MRI. This lesion is a cystic lesion in the floor of the mouth with multiple foci of calcification representing philippuli. And you know the presence of philippuli in a soft tissue mass that is enhancing is one of the helpful diagnostic criteria for hemangioma of the floor of the mouth. And hemangioma will appear of very, very bright signal in the T2 weighted image, and you can see within the hemangioma some of the philippuli, but you know that CT is more sensitive for detection of calcium compared to the MRI. هذا وبالله التوفيق والحمد لله رب العالمين.